Thank you for joining me today. In this video, you will learn how to conduct a psychiatric interview for older adult patient. It will be same as the adult patient, but in older adult seniors, when you want to conduct a psychiatric interview, you want to concentrate on you will emphasize greatly on cognition, mental illness, medical illness, function, high risk for delirium, dementia, medication side effects. You want to emphasize that more than other adult, because older adult seniors are more sensitive to medication side effects. They go through delirium and dementia. Always consider for medical and neurological side effects or causes first, instead of thinking psychiatric causes for their confusion or irritation or psychosis. You want to consider neurological causes or medical causes first. You want to collaborate information with the family, caregivers, and medical record. You must see the patient alone, at least briefly, to assess the mood, paranoia, suicidal ideation, and repeat the exam may be needed due to a fluctuation of mental status. So you want to see them first, and then you want to repeat them later. You want to know if they are having that delirium, dementia, if that confusion improved, if their psychiatric status is improved. You want to do that, repeat the assessment later. Assessment to focus on is cognition. You want to assess the delirium, dementia, mild cognition impairment, mood disorders like depression often present typically, psychosis, later onset of psychosis, or medical causes. You want to assess those. Medication effect, or if they are polypharmacy, if they are using many different medication that cause this psychosis or this confusion. You want to assess that. You want to assess the safety for self-harming or self-neglect, older abuse or falls. You want to assess those. For history, onset, course of the disease, symptoms, if they are acute, if they are gradual. You want to have a baseline of the memory, attention, intelligence, personality, mood. You want to have that history of their personality, how they been, is any mood change, personality change, attention change, do their intellectual change, do the mood change, motor function. You want to assess that. Daily routine, you want to assist the daily routine, self-care, financial, driving, social, religion activity. You want to assist also those. You want to assist the medical history, like infection, if they have stroke, if they had a history of stroke, Parkinson, hair trauma, you want to assist those. This will be the part of a psychiatric interviewing and history gathering. And medication, you want to review the critically, you want to review the prescription, out of the counter, if they taken any out of the counter medication, herbal remedy if they are taking. You want to also review the discontinued medication. You want to review family history. You want to review the dementia if they have a family history of dementia, depression, alcohol use disorders, sensitivity to deficiency, hearing loss, vision loss, recent stress like loss or hospitalization or institutionalized like nursing home, group home, if their life change. You want to assist their function. You want to assist the LDLs activity of daily life, if they are doing their own bath, dressing okay, toileting, eating, grooming, financial, medical, if they are cooking, if they are still driving, or if they have transportation. Functional decline, you want to assist the functional decline if they are often preceded by diagnosis of neurological disorder. If they have neurological disorder, that will lead to decline, functional decline. You want to assist the mental status examination for geriatric. You will emphasize their appearance, behavior, hygiene, gait, posture, speech, aphasia, if they have aphasia, dysrhythmia, slow output, mood, depression may be present with empathy. You want to also assess the risk of falls, risk of self-harm, especially with loneliness and illness, status and consent. You want to assess for if they are having a psychosis symptoms like delusion or hallucination or paranoia or obsession or SI or HIs, if they are perception, you want to assess hallucination, thinking, medical or neurological. You want to assess their cognition, orientation, perception, attention. For the key for the attention will be delirium. If they have any delirium, assist their mental and memory, immediate memory for the immediate, recent and remote memory. Immediate memory, recent memory and remote memory, those you want to assist that. Excessive and visual focus. Insight and judgment, you want to assist that. Capacity for decision making. Common tools to use will be MMSE, maximum of 30, Geriatric Depression Scale, include a somatic symptoms, medical considerations include high prevalence of comorbidity for medical illness, common version or comorbidity include infection, metabolic electrolyte impairment, if they have a thyroid disease, if they have vitamin B12 deficiency, medication toxicity like anticholinergic or benzodiazepine. You want to require evaluation, maybe include CBC, electrolytes, vitamin B12, folate, urinalysis, EKG, MRI for a cognition decline. You want to conduct those. EEG for delirium, if you suspect delirium or diffuse slow. Also you wanted, and differential diagnosis will be delirium, will be dementia, depression. For delirium, you want to assess if that is acute onset, fluctuation chorus, impaired attention, impaired concentration. Of you want to see if they have any hallucination, or you will use the EEG for diffuse slow. Okay. Dementia is a major neurological disorder. It's gradual and progressive decline. It has a progressive decline, clear consciousness. Alzheimer mostly common, and low body dementia. They have a low body dementia, frontal lobe dementia, depression, predominantly compliance of the memory loss. If the patient has a depression, they will have it will affect their memory. Cognition deficit improve with the treatment. Mood symptoms primarily. Normal aging will be mild forgetfulness, preserve function. So the treatment plan will include treatment underlying medical causes, prioritize safety and functional independence, use multiple primarily approach, multiple disciplinary approach. Medication start slow and go slow. Minimize anticholinergic medications, anti-psychiatric medication only if it's necessary, and behavior disturbance or psychosis. Non-pharmacological interview refer to environmental modification. They could fall, so you want to do that. Caregiver, you will educate the caregivers. Psychosocial support, you will engage the family and caregivers with the plan, and you will involve them with the plan, treatment plan. Advance directives and decision making capability. Assess the decision making capacity. You may involve guardianship, power of attorney, advance directives, document baseline function and changes clearly. So, visual hallucination in elderly is medical cause until otherwise. So mostly it caused by medical. Inattention equal to delirium. Always ask it directly about suicidal ideation. Functional decline is often an early sign of dementia. Polypharmacy is a major reversible risk factor. Thank you for joining me today. Please subscribe and join me in my next video. Thank you.